Olá, tudo bem? Agora a gente vai conversar com o Dr. Marx. Ele é um neurologista, diretor do departamento de Distúrbio de Movimentos aqui do Utilizam. Dr. Marx, a gente gostaria de saber como é organizado o departamento de Distúrbio de Movimento aqui no Utilizam.
So we have developed a comprehensive movement disorders program here that is organized around the patient, and there are several key parts. The first part is establishing an appropriate diagnosis, and for that we use a team that consists of neurology, physical therapy, occupational therapy sometimes, orthotics, the people who make braces, and we use support services that have a social worker and a nutritionist that also come to clinic to help us. We work together to create a diagnosis based on our history, based on our clinical exam, and then whatever testing we think is necessary to come to the right diagnosis for the patient. And so once we have a diagnosis, then we can work on a treatment plan.
Yeah, really good. E eu queria saber agora quais são as principais bases para um bom planejamento de um paciente pediátrico com distonia.
Okay, so the key to establishing a treatment plan is understanding what the movement disorder is. Is it pure dystonia? Is it dystonia with other things like spasticity? Is it dystonia with things like myoclonus? So first I have to probably understand all the terms. So dystonia is where the messages from your brain to your muscles get mixed up. And in essence what happens is your muscles fire in the wrong order. So for example, if I go to bend my elbow, my brain has to tell my muscles in the front of the arm to fire and the muscles in the back of the arm to relax in order to make my arm. And when I go to straighten it out, it's exactly the opposite. These get activated, these relax, my arm comes back out. When you have dystonia, the muscles all may fire at the same time. So I go to bend and they want to bend, but the arm wants to go out at the same time. And so you begin to get these twisting, writhing, continuous movements, and that is what we call dystonia. Spasticity, on the other hand, is when the brain doesn't tell the spinal cord to relax, so the muscles are too stiff. But they don't get this twisting. What you get there is just a resistance to movement. So the faster I pull, the more resistance I get. Okay, so that's what we call spasticity. Okay. Myoclonus are these quick, jerky movements that may go in kind of any direction. So you have to figure out which of the movements you're trying to treat to establish your treatment plan.
Okay.
Once we know all that, then we set goals with the family. So what is it that we're trying to make better? Is it your walking? Is it your hand movement? Is it your speech? Is it your independence? You know, what are we trying to do? And from there we can begin to establish a treatment plan.
Okay, perfect. E, na sua opinião, qual é a estratégia mais promissora atualmente para o tratamento da distonia?
Okay, so there are some viable, some good treatments available for dystonia. None of them are perfect. Dystonia is a very, very difficult movement to deal with. So we generally start with physical therapy. We may add medicines that you take by mouth, and then if those medicines are not effective and physical therapy is not effective, that's when we consider more advanced treatments. So the treatments have now moved from medicine into the realm of neurosurgery, and really for dystonia there are a couple of options. One is deep brain stimulation, which involves taking small wires, putting them down into the deep structures of the brain, and programming them with a pacemaker. So just kind of like you have a pacemaker for your heart, this is we would think of this as a pacemaker for your brain. And we can change the programming of the pacemaker to deliver different amounts of electrical impulse to change what we're trying to do in an effort to get control. Okay? The good part of the DBS, or the deep brain stimulator system, is that we can continue to program it. The bad part is it does require maintenance, because you have to change the programming, and it is a battery operated device, so after a while the batteries will need to be replaced. With our rechargeable system that we use right now, the battery life is about 15 years. So we have a long time without having to replace anything. Okay. It's still a surgical procedure, and there are some risks of the surgery, infection, things like that, as with any surgery. The other option, and we don't really do that much here, is to cause a permanent lesion, to do what's called either a pallidotomy or a thalamotomy. You don't see that being done as much anymore, because once you create it, you've done, and you can't really modify it that easily. Okay. So we tend not to do those kinds of permanent procedures. We like things that we can adjust and we can reverse if it's not working. Okay. For spasticity, so if it's not dystonia and there's more spasticity, for example, a premature baby, then if we're really trying to just affect the lower extremities, then we can think about the surgery that we call a selective dorsal rhizotomy. Okay? Rhizotomy is not a good surgery for dystonia. Okay? In fact, dystonia may be a reason not to do a rhizotomy, or at least to be careful with your rhizotomy. Okay? But if your problem is spasticity in your legs from cerebral palsy, then rhizotomy may be a good choice. Again, if you don't respond to oral medicines or the botulinum toxins and things like that, then rhizotomy may become a choice for you.
Okay. Thank you so much for that. It's been an honor for us from Ventilations Live here in Curitiba.
And it's been great to have you. Hopefully we'll get a chance to come visit you in Brazil.
Yes, hope to see you there.
Okay.
Thank you
All
very
right.
much.
Thank you.